You also need to know who will I call, and sometimes it's a complicated question. Who will I call? It seems quite simple. But you have a team taking care of you and your DBS. Perhaps you have a neurologist, a programmer, and a surgeon. So you might start off with a programmer, but then it might be a surgical issue. Make sure you have all that information. Don't throw away the information from your surgeon because you had the surgery 5 years ago and hopefully will never need it again. Always keep that information available to you. But we can predict and prepare, for instance, for battery end of life. So fortunately, your programmer and you can work together and predict that and put a strategy in place before the battery wears out. But that also speaks to the need that in order to predict and prepare to have that close follow-up. If you're doing well and the DBS is treating your tremor and you have essential tremor and everything is beautiful, you still want to make sure that you see your programmer or your neurologist or whoever is following your DBS system, whether it be every 6 months or 12 months. And there's some variables that are important to us that we decide what that interval should be. Because some of the things that I've seen are people who have had tremor, have done well. We don't need you anymore. We're doing so well. But we don't want anything to happen, and we want to be able to be prepared for any changes down the road. And there's multiple people on your DBS team. Don't forget about your neurologist if you have a DBS programmer, because they still have a big role in your care, whether it be dystonia or tremor, if you're on medicines, dealing with medicine side effects, when you need to change medicine, helping with the discussion of when your symptoms, if they change, are related to DBS or disease progression that DBS will not fix. And then there's many other problems you may have that DBS does not tackle and does not improve. The other thing is make your primary care provider a central part of the team. Everyone in this room should have a primary care, a general practice, family practitioner, internist to take care of them and be part of the team. And that also means educating them about DBS as well. Now, what about some emotional and adaptive changes to DBS? And I think this is an area that Sierra and I, we've taken care of hundreds of patients. We're learning more and more about, because this is an area that changes as far as our understanding of DBS. So sometimes there's a tendency to look around and look how dramatic DBS can be. So if only I had that treatment, everything will go away. All my life's worries, all my symptoms, all my problems. Maybe my kids will behave better, my spouse will behave better, my neighbor will behave better, right? But when you see such a dramatic treatment like this, it's very easy to fall into that slippery slope that everything will be better for me if I get this treatment. And my hope is that many things will be better for you. But there still are issues that the DBS cannot change. And I'll talk about some of the motor symptoms that we expect to improve and not improve. But also, when you have the discussion, if you're thinking about, is DBS good for me? It's important to really think, okay, if I take away my tremor or if I dramatically reduce my tremor, what does that mean to me? What can I do differently? Or how is it going to change my life? Sometimes it could be the best thing. Sometimes you might have an improvement in tremor, but your balance is still your biggest problem and was always your biggest concern. And the DBS may not change the balance for you. So these are things, it's a hard thing, again, to get your arms around and understand how this is going to affect you. Because improving some things still means you may have some other problems that you have to adapt to. The other thing that we see is after DBS, everything's going to change. I'm going to be able to go back to work. Work is going to be great. I'm going to be able to deal with everything. Well, there are still life's adjustments. And it is not always the case that everyone that has DBS, even with beautiful improvement in movement, can go back to work. Because there can be a lot of things that affect how you manage and perform in the work environment. Maybe anxiety is an issue. Maybe there are cognitive features that are issues, and maybe just the adaptive changes to having had Parkinson's over time and the stress of big change in your life is too much. So it really takes some discussion and some introspective thought to think about what will it really mean to me to get DBS and to live with DBS. It's a wonderful treatment, but not a panacea. Also, when someone originally has the surgery, one of the biggest fears that we hear is, what happens if I wake up tomorrow and it doesn't work? This is a big thing for many people, and it's a realistic thing to have this fear when you have this surgery and you get this treatment. And so that's something I suggest, and I hope that you talk to your provider about if you have these fears, because this is what you do, and these are the steps you're going to put in place. Also have that discussion. If the DBS, for whatever reason, has trouble, what do I do? And you want to know that beforehand. I'm going to give you one example about realigning expectations. So sometimes it's important not only to review your expectations for surgery, but your family members, your significant other, or what have you. There was, I remember a discussion with a patient in Cleveland, an elderly woman that had DBS, and her goals were to treat her motor fluctuations. She had Parkinson's, so increase her on time and reduce her off time. An elderly woman, balance problems and so on. Her family's expectations were that mom could now keep house again and do the laundry and go up and down the stairs and be there to be the cook and so on. And now it's too much for her. So these are real stories and real expectations. So that's what I mean by what do you expect DBS to do for you, and does it align with what we think it can do for you? So we have people in the audience with Parkinson's, dystonia, and tremor, and I broke this out into the different disease groups. So for Parkinson's disease, deep brain stimulation really helps the symptoms that dopamine helps. So the symptoms that levodopa helps, and those of you that have heard me before have probably heard this statement, DBS does only as good as medicines, which is a surprising statement, because why on earth would I have surgery if it did only as well as medicines, right? You would just opt for medical therapy. Well, the issue is, as the Parkinson's progresses, that on time gets shorter and shorter. So we can use medicines to help you move, but the time of its effectiveness decreases over time. And we have some manipulations we try to make with the medicines, but in doing so we might cause some uncontrollable movements, right? And so there's only so far we can go with the medicines. Or sometimes there's some unique symptoms that medicines never even really treated well, but we know DBS treats well. And that would be tremor or dystonia. And this is really very important when you have DBS, because down the road, you're going to come to your doctor and say, I feel worse. We need to tweak and change my DBS programming. And then we'll say, well, what's going on? What's changed? Well, I'm freezing more. I'm having balance problems. Or maybe speech and swallowing is worse. So what's the next question that we ask? Do these symptoms tend to occur when your medicine wears off, or are they just random throughout the day? Because these particular symptoms are symptoms that over time, as the Parkinson's progresses, are less responsive to medicine. They involve areas of the brain outside of those dopamine nerve cells, outside of that circuitry that the DBS is really designed to target. And that's really important to know, because changing the DBS and changing the DBS and changing the DBS won't help these symptoms perhaps for you. And so you need to know when it will or won't. Sometimes we don't know where someone is with their Parkinson's, and sometimes we actually bring people in the clinic and start over and have them come in off medicine, see what they look like off, see what they look like on, to see if that new symptom or that new problem is responding to medicine. Should we even target DBS changes if we have any room to go with the stimulation? Because stimulation is also just like medicine. Getting it right is so important, but more does not necessarily mean better control, because the field of stimulation, that electrical current, will spread to areas of the brain that we don't want to stimulate, and then that causes other side effects and other issues. So there is a tendency to think that the DBS stimulation is working, it's good, more means better, more means better, more means better. There is a limit in what we can do, and we need to be respectful of that limit because we can cause troubles. So especially the balance, the freezing, getting stuck, the speech and the swallowing, those are concerns that as they change with the Parkinson's, they're less responsive to levodopa and tend not to be responsive to the DBS. So that's important to keep in mind. The other is DBS won't necessarily change non-motor symptoms. Sometimes we get some benefits. Sometimes we can cause some problems with DBS, with inappropriate programming, and if it's in the wrong place, we can actually cause mood problems with subthalamic nucleus, or STN DBS, and we don't want to do that. Thinking problems, memory problems, cognitive issues, if they are a problem, DBS won't help that, but other things can. And the bowel, the bladder, the sleep. We do have people where the constipation does get better after DBS. We do have people where the sleep gets better after DBS. And there may be a lot of reasons for that. They're more comfortable, they're not wearing off, maybe they're exercising, they're more active, other lifestyle issues, but maybe there's a direct connection. We just don't know. Dystonia, there can be so many different causes of dystonia. And you can have primary dystonia where that's really your only problem and your only symptom. Or you can have secondary dystonia where the dystonia is caused by something else. You can have dystonia as part of your Parkinson's. And how much we expect the DBS to help dystonia depends on many of these things. If it's a primary dystonia, and that's a certain type of disease, certain type of syndrome, it tends to work very well. If it's a secondary dystonia, there, for instance, an example of secondary dystonia is dystonia after head injury. Or there's some specific metabolic diseases that cause dystonia. Or dystonia after a stroke. Tends not to work as well, although there have been some isolated benefits reported in the literature. Also, what the dystonia looks like might affect the improvement in dystonia with DBS.
Quick question. Could you define dystonia?
Dystonia is a sustained involuntary contraction. So it's a contraction of the muscles. And it could be at anywhere in the body. It could be the neck, and the neck is pulling. Sometimes that's called torticollis. It could be in the arm, and the arm is pulling up. The foot is cramping, curling, turning in. The trunk is twisting. So this contraction actually causes pulling, twisting, turning because of the muscles super contracted. It is another brain condition. And I'm sorry I don't have enough time to talk about all the specifics of these brain conditions. Dystonia could be a part of the Parkinson's. If you have young onset Parkinson's, sometimes it's a symptom that presents just like tremor. If you have dyskinesia, you can have dystonia as part of your dyskinesia. So many of you might be more aware of dystonia as a part of dyskinesia. So when you have extra movements, you might have a sustained pulling of your arm or your neck. That would be an example of dystonia in Parkinson's, for instance. And dystonia, again, because DBS very much helps the dyskinesia and very much helps the dystonia that goes along with the dyskinesia with Parkinson's tends to improve.